Welcome to this explainer on the Temporomandibular Joint, or as you probably know it, the TMJ. I am absolutely thrilled to guide you through this today. We're going to be taking a really close look at a ridiculously complex piece of biological machinery that we rely on every single day. I mean, we use it to speak, to laugh, to eat. It's literally an engineering marvel tucked right inside your head. But before we dive into the deep anatomy, I want you to try a quick experiment right now. Place your finger just in front of the tragus of your ear. You know, that little bump of cartilage right in front of your ear canal. Now slowly open and close your mouth. Do you feel that sliding, hinging movement? That mechanism right there is exactly what we are going to explore. We're looking at the perfectly synchronized bilateral components of a single craniomandibular articulation. So here is our roadmap for today. We'll start by locating the atypical joint, then we'll build the articular surfaces, explore the shock-absorbing disc, look at the ligaments acting as seatbelts, fire up the mechanics of mastication, and finally, look at what happens when the TMJ actually fails. Okay, part 1, locating the atypical joint. To really grasp how the TMJ works, we first need to define what makes it so incredibly unique compared to almost every other joint in the human body. The TMJ is defined as an atypical synovial joint. Notice that word, atypical. Your lower jaw, the mandible, is a single bone with two heads that articulate on each side of your skull. And because the cranium and the mandible are both single, rigid components, you simply cannot move the joint on one side without simultaneously moving the joint on the opposite side. They are perfectly synchronized bilateral components functioning as one single mechanism. Moving on to part 2, building the articular surfaces. Now that we know where it is and how it behaves as this unified system, let's actually build this machine. We have to start with its structural frame, the bones. The upper articular surface is formed by the temporal bone. Specifically, it's a concave hollow called the articular fossa paired with a convex bump right in front of it called the articular eminence. Meeting this whole structure from below is the lower articular surface, which is the elliptical head or the condyle of the mandible. Now, here's the crucial part. These opposing shapes aren't just for show. They actually divide the joint's function. The upper compartment, which interacts with that concavo-convex temporal bone, handles the gliding movements. Think about when you thrust your jaw forward or pull it back. Meanwhile, the lower compartment works with the elliptical head of the mandible to act more like a hinge. It permits the rotational movements we need for the basic opening and closing of the mouth. And this structural distinction is exactly why it gets categorized as an atypical joint. In a standard synovial joint, like your knees or your elbows, the bone ends are coated in this smooth, glassy hyaline cartilage. But the TMJ handles immense, repetitive pressure. So instead of hyaline, these articulating surfaces are covered by a dense, incredibly tough layer of fibrocartilage. It's built specifically to withstand the daily grind of chewing, literally. Part 3, the shock-absorbing disc. Because these fibrocartilage-covered bones undergo such heavy friction and pressure day in and day out, the joint requires a heavy-duty shock absorber placed right dead in the middle. Enter the intra-articular disc. This disc essentially splits the joint cavity entirely in two, creating that upper and lower compartment we were just talking about. It's a specialized pad of fibrocartilage sitting right between the condyle of the jaw and the temporal bone above it, and it acts as this dynamic cushion that actually moves as you chew. If we look at a sagittal cross-section, so a side view, we see the disc isn't just a simple uniform pad. It is highly engineered with 5 distinct zones. From front to back, it features an anterior extension, an anterior thick band, a thin intermediate zone, which, by the way, is exactly where the pressure is highest, a posterior thick band, and finally an incredibly important posterior bilaminar zone. Why is that last one so vital? Well, it's rich in elastic fibers. When you open your mouth wide and the disc glides forward, it's this elastic bilaminar zone that actually recoils like a rubber band to pull the disc safely back into the articular fossa when you close your mouth. Part 4. Ligaments, the joint seatbelts. So we've got the bones forming the frame and the fibrocartilage disc acting as the shock absorber, but what keeps these complex, moving parts from flying completely apart when you take a massive bite out of an apple? Ligaments. They act as the joint seatbelts. The entire joint is first secured by a fibrous capsule enclosing the cavity. Fascinatingly, this capsule is loose above the disc to allow for that gliding motion we mentioned, but it's really tight below the disc. Strengthening this capsule on the outside is a powerful lateral ligament. Its primary job is absolutely crucial. It physically stops the jaw condyle from being pushed too far backward, which protects the delicate structures right behind the joint. Plus, there are 2 accessory ligaments that help suspend the jaw.
the Sphenomandibular and the Stylomandibular ligaments. And there's a fantastic piece of evolutionary biology hidden right here in your jaw. That sphenomandibular accessory ligament, it lies on a deeper plane and gets completely taut when you stick your jaw out. But anatomically, it's actually a remnant. It represents the unossified intermediate part of the sheath of Meckel's cartilage from our embryonic development. So it is quite literally a piece of our developmental history holding our jaw in place. How cool is that?
Part 5, the mechanics of mastication. All right, we have the bones, the shock absorber, and the seatbelts. Now it is time to add the engine to our machine, the muscles of mastication. Here are the 4 principal muscles that serve as the prime movers for everything from talking to chewing: the temporalis, the masseter, the lateral pterygoid, and the medial pterygoid. A key anatomical fact to remember about these 4 is that they're all located around the infratemporal fossa, they all insert into the mandible, and they are all exclusively innervated by the mandibular division of the trigeminal nerve. These muscles work in a brilliant, synchronized concert. If you want to depress the jaw, meaning open your mouth, the lateral pterygoids pull the jaw forward and open, assisted by gravity and a few smaller muscles. To elevate it, or snap it shut, the powerful masseter, medial pterygoid, and temporalis engage. And for that complex side-to-side grinding you need to actually chew your food, your medial and lateral pterygoids of one side contract alternately with those on the opposite side.
Finally, part 6, when the TMJ fails.
Now, as with any highly intricate machinery, clinical failures do happen, and they can manifest in some pretty surprising ways. Consider this clinical anecdote straight from our anatomical sources. Picture a medical student in a long lecture yawning just a bit too widely. The lecturer, maybe feeling a little annoyed, walks over and gives the student a sudden tap on the chin. The student immediately tries to apologize, but he can't. His jaw is entirely locked open. You see, when the mouth is open wide, the mandibular condyles move to their absolute most unstable position right underneath the articular eminences. That sudden bump to the chin caused the condyles to slip completely anteriorly into the infratemporal fossa. This is known as an anterior dislocation. And a quick warning, any effort to passively force the mouth closed at this point will invariably fracture the neck of the mandible. No way we want that. So, how do we fix it? Well, the medical procedure requires an orofacial surgeon to place their thumbs deep inside the mouth on the very last molar teeth. They must simultaneously push down hard on the back of the jaw while forcing the chin upward. This physically slides the bone back over the eminence and plops it safely back into its socket. Of course, even without a dramatic dislocation like that, many people suffer from what's collectively known as Temporomandibular Joint syndrome. This can present as diffuse facial pain resulting from spasms of the master muscle, persistent headaches from temporalis spasms, or specific jaw pain from lateral pterygoid spasms. Perhaps most famously, though, it's often accompanied by an audible clicking sound. That click actually happens when that vital, shock-absorbing disc we discussed earlier becomes stretched out or temporarily trapped in front of the condyle while you're chewing.
So, we've covered everything from the specialized fibrocartilage right down to the pterygoid muscles that drive the whole engine. The next time you take a bite of an apple, chew your dinner, or even just let out a massive yawn, take a moment to appreciate the flawless, bilateral, mechanical ballet happening right in front of your ears. It really makes you wonder, doesn't it? What other invisible machines in your body are working flawlessly right now without you even noticing? Thank you for exploring the temporomandibular joint with me. Keep wondering and keep learning.